Hi, everyone. Thanks for joining us today for our SHAPE Update webinar. We're going to get started with Dr. Ben Miller presenting.
Good morning, everybody. Thanks so much for the time today. I'm really excited to be able to share with you just a little bit about this project that many of you have been working on so diligently for the past couple of years, and also happy to share the stage with several colleagues who are also on the line. You can see their names here. What we've envisioned for happening today is I'm going to walk through just a really quick overview of how we got to where we are. Going back and looking at the history of how we landed in this wonderful place that we now call SHAPE, and remind you of just a couple of the points that really led us to the place that we find ourselves right now wrapping up this project. I then am going to turn it over to my colleague, Dr. Brown-Levy, who will talk a little bit about our evaluation timeline for those of you that are curious as to kind of where are we going with the data, when do we need to have all our data in, and what is it going to look like. And then we'll wrap up with Mr. Gordon, who will talk to us a little bit about his perspective from a Rocky perspective, a payer perspective, this project, and some of the importance of how SHAPE is also informing not only local efforts, but also some of the efforts statewide and even nationally. All right, so let's get going here. Next slide, please. Some of you may recall this map. This map was the bane of my existence for a little while because of what it doesn't say. But this map actually started a story that I think is really important and that many of you now are currently in the process of living. We understood back in 2008, I'll never forget this, we're at a breakfast meeting, eating Danishes and drinking coffee at the Colorado Health Foundation, and somebody asked the question, well, how many of you practices that are integrating behavioral health are able to sustain yourselves? And it was one of those just awkward party moments where nobody raises their hand and everybody kind of looks at their shoelaces and kicks the floor, and no one really understands, how to answer that question, because the answer was that nobody was sustainable. And it got us thinking, and it got me thinking, it got the foundation thinking, got a lot of folks thinking, oh my goodness, this is kind of a problem. If we've awarded close to 40 grants here in the state of Colorado to sustain or support behavioral health and primary care, what's the problem that our grants aren't solving? Next slide, please. And so some of you may have been a part of this and may remember, oh, there we go. I forgot about the automated piece here. You can read all that. I already said it. We knew a lot of the funding for the grants really just supported the clinical piece, but there was so much confusion out there on how to sustain it that we needed to go upstream a little bit. Now the next slide. Okay, so we did a survey, and many of you on this call and our many friends helped develop this survey, where we put out a bunch of questions to practices that had integrated behavioral health, and we wanted to find out kind of how are you paying for yourself? What does that look like? And thanks to our good friend Steve Mellick, we came up with a pretty robust list of answers to the question of how are you supporting yourself. Next slide, please. And you can see here, there's just a million things on there, not really that relevant right now. This is what we found, and this was reported out in the final product that came from the Health Foundation, but the vast majority of practices were sustaining themselves purely on the back of a grant. And so when you look at providing a population-based approach for behavioral health and primary care, and the only way that your program is alive is because of a grant, it kind of puts yourself in this really uncomfortable and awkward moment where you are offering something really wonderful, very generous to the community that's going to go away. Because grants have a hard time sustaining themselves, as we all know. The soft money is a wonderful thing to have when you have it, but it does eventually dry up. Next slide, please. So there were 5 recommendations that came from the survey, and this is old hat for many of you, but it really is the context for SHAPE. Everything that we're going to talk about moving forward with this wonderful evaluation and project is built off of these 5 recommendations. So the first recommendation, and again, thanks to Steve for helping us with the offset data here, was we needed to be able to look at how to pursue same-day billing codes for physical and behavioral health. Well, as it turns out, many of you already know the end of the story, Medicare, which is actually very supportive of looking at things like same-day, we found that there was just confusion around same-day billing practices, and that it depended on the state or how the state administrated the opportunity to bill for a same-day behavioral health and physical health that really got the field a little bit confused. And so we needed to clarify what was allowed and what was not allowed. Well, Steve, in his brilliance, showed us that in order to pay for 1,000 same-day visits, 30-minute sessions here, or visits. All you would need to do is prevent 6 inpatient admissions to pay for 1,000 of those. So we had the data, we had the compelling case as to what actually needed to occur. But it turned out that this wasn't really anything that, this recommendation wasn't anything we really need to move on, because it didn't seem that relevant for a lot of folks in our community. Next slide, please. The other thing that we did was we had a recommendation around looking at the health and behavior assessment codes. Many of you are familiar with these codes. They're billable in 15-minute units. They are really for folks like behavioral health providers. I mean, they're for any provider, honestly, but for behavioral health providers to bill for a non-mental health visit. So they're seeing Ms. Smith to help her with their tobacco cessation. They can drop a bill for a health and behavior assessment code. Medicaid does not have these codes open in the state of Colorado. And so one of the recommendations was, why don't we just open them up and see if that would provide more sustainability for practices. When we had more meetings and we had more conversations with a lot of you and a lot of the other leaders in the community, it turns out that maybe this wasn't the biggest bang for the buck in order to help with sustainability. Next slide, please. Recommendation number 3, which is it's kind of the godfather of where SHAPE came from, was the recommendation to test and analyze the viability of global funding strategies to financially sustain integrated care model. Now remember the partners that were at the table at this stage of the game. We had the Health Foundation, we had CFHA, Collaborative Family Healthcare Association, we had a lot of folks in our community, including many of you on the phone, that were really sitting there saying, we need something bigger. We need something more audacious that's going to really challenge the status quo and get us to think about payment in a very different way. Next click, please. There were 2 other recommendations, one around clarifying current billing regulations, and that actually came out with a report that I think is helpful, but really just clarified a lot of what you can and can't do. And then recommendation number 5, which is somewhat of a throwaway point, because we all understand the importance of having a standardized statewide data collection system. It's a bit like boiling the ocean. It is important, but it is unbelievably complicated and cumbersome. Next slide, please. Okay, so all of those events, all of those data points, all of those stories led up to a really wonderful serendipitous moment where we understood that we had to go bigger in order to really basically collect the right kinds of data and evaluate new payment models that support behavioral health and primary care in a very financially solvent way. Through our partnership with Rocky Mountain Health Plans, the Collaborative Family Healthcare Association, and us here in the Department of Family Medicine, we started talking about, could we evaluate a leader in Colorado who's deciding to look at supporting behavioral health and primary care a little bit differently. And when we look around the table, there's quite a few folks in the state who are very invested in this topic. But Rocky at the time, and I'll let Patrick share a little bit more about his story in a minute, was the one that was really at the forefront of pushing for this change. And so SHAPE, in essence, is an evaluation of Rocky's changing the payment for how we deliver integrated behavioral health and primary care. To be very clear, this is not a grant. This is not where we are giving you money to sustain your efforts, because then we'd be replicating what we saw was the problem initially back in 2008, where practices just got a bunch of money and they couldn't sustain it. This is about us truly testing a new payment model that is hopefully and ideally, and of course why we evaluate it, going to lead you as a practice to a place that you're solvent financially. Simultaneously, it's also going to inform our payer friends, Rocky in this case, on what works and what doesn't work when it comes down to paying for behavioral health and primary care very differently. So I'll never forget that it was the day after, I think, Mr. Gordon and his colleagues had put out a small press release on this project, that we were contacted by several states wanting to know what the payment model was. Everybody was all up in arms. What is the payment model? How are you going to do this? What does it look like? And this was day one, and we didn't know. Well, I think we know a whole lot more now, and we're still learning. And so today, what you're going to hear is just us reminding you of the importance of the role that you're playing. It's us reminding you that you're leaders in your community as to how to foresee what a new and novel payment model will actually look like. There are many efforts afoot right now, including those that we'll talk about in just a second, that really are going to rely on our understanding of what's working for you, what's not working for you with this new payment model, and then what is it that we can improve upon. One thing here, and this is kind of the second bullet point that you can see, we wanted to be able to test the alternative payment model to sustain behavioral health in primary care. When your friends ask you about SHAPE, the way that I would say it, and the way that I would really frame this up, is that we are all about testing what's working and what's not working for a new payment model. And next slide, please. And it's in service to an understanding that when we, next click, please. When we look at the vast majority of behavioral health programs in primary care in the country, we find that they focus on that middle range area, that really traditional mental health and substance use. But what we wanted to do with SHAPE, and I think Patrick said it really well, is that we wanted to provide unfettered access to behavioral health so that behavioral health providers can address the range of need that's presenting in primary care, so that it might be a patient that's showing up in your practice that simply needs assistance with transportation. Or it might be a patient that shows up in practice that is really kind of struggling with some of the management of their emotions secondary to being diagnosed with diabetes. Or it might be the patient, and you guys get the game here. I mean, this is how we go. Traditional payment milieu, which SHAPE tried to totally eradicate, forced behavioral health providers into their really small, circumspect silo to do just one thing, which is around traditional mental health. And we wanted to break that down. And we wanted to find out, when you changed the rules of the payment and you allowed for behavioral health to deliver a truly population-based approach to care, do people get better? Do primary care providers' behavior change? Qualitatively, what's the experience like? How is it different? And these are the questions that we are in the process of analyzing and answering, and many of you have been so gracious in helping us understand that. But make no mistake here, we really have to be prepared for the next. Next slide, please. That's a beautiful color, Emma. And the next is really going to be built off of what Chandra will talk about here in just a second with the evaluation. Colorado applied for and has been in the process of applying for a state innovation model cooperative agreement now to CMS. It's literally been 2.5 years. And some of you have been a part of these meetings and have come to the meetings and shared your story. But if you look at underneath all of what's been written within SIM, and then the website's coloradosim.org if you want to go look now. But underneath it all is really an understanding of we have to build off of our successes. We do not want to be deficit focused and talk about all the barriers and woe is me, change the policy for this, that, and the other. We want to talk about scaling experiments that have naturalistically occurred in our community that work. And since the focus of SIM will be around behavioral health and primary care, we have to have a sustainable financial model. We've got to have something that we're looking at kind of aiming towards all our payers so that it's not just Rocky Mountain Health Plans who's literally leading the charge as the front runner here, but that we have other payers that step up and decide that they want to invest in comprehensive primary care the way that Rocky has. So that's the kind of the history, the context, and where we are now. We're 2 years in, and Chandra can give you the update here in just a second on our timeline. But I do want to kind of close my comments with a thanks. And many times in the work that we all do, we don't get that. We're asked to do a lot of things, and we're asked to kind of constantly change what we do, how we talk, how we behave, what we think, all that other stuff. SHAPE is a living kind of personification of us saying, let's try something different. But what SHAPE is doing, which I hope many of you see, is it's giving us all hope. You may not necessarily see this now, but hopefully those of you that are going to be, and many of you will be, at the Collaborative Family Healthcare Association conference this week, which is why, again, we wanted to kick off the week with this so that when your people are coming up to you afterwards and saying, tell me about SHAPE, you remember where we came from. But you give people hope. There are other states, there are other practices across this country that aren't necessarily in a position where they have a friend like Rocky that can help them. They're not in a position where they've got practice leadership or vision like a Greg Reichs who is supportive of behavioral health. They're not necessarily in a position that they can collaborate with their academic partners in the community to answer meaningful questions instead of just be, another guinea pig in a cage. And so I really do want to kind of implore you all to take ownership of that and see it for what it is, and that you are leaders. And when the natural thing that happens with leadership is that people ultimately follow. And so you will be a wonderful case for folks to follow. So I'll stop there and turn it over to Chandra, but thank you all very much.
So I'm just going to speak a bit about our project timeline from an evaluation perspective. As many of you know, Emma Gilchrist and I focus a lot on the evaluation efforts for SHAPE, and this slide serves as an orientation as to where we currently stand in the evaluation process. So several measures have been completed, several are still in progress, and there are a few to look out for in the coming months. So if you look at this table, you can see that we've already completed the initial PIF, or the practice information form. We've also completed the initial qualitative interviews, and we've completed the first and second site visits. Along with that, we've also done the initial cost tool and workflow. And this is something that we initially did on the paper or Excel forms, and we had several different iterations that we worked with you all on, back and forth over email, sometimes in person, and sometimes on calls. Some of the progress that we're currently under right now, looking at some of the things that just are currently underway, or the first iteration of the behavioral health tracking form. So some practices have completed this and some are still working on this. We are also looking at our EHR data extraction. So several practices have spoken with me and with Emma about this, but there's also other people on the team that are part of this. So you may also be speaking with people like Kim Brown and Fern Epstein as we move through the data extraction component. We're also keeping our monthly practice check-in calls on a monthly basis, and we'll continue to do that for the entirety of the project. Towards the end, we'll be letting you know when those are wrapping up. That'll be more towards January and February. And then you also all received the Coach Online tool, which is taking place of the final cost tool and workflows. So we're very interested in your feedback on that tool, and we've received some feedback already, and we welcome continuous feedback on that, as we're trying to make it as easy to use as possible and as informative as it can possibly be. Some of the things to look out for in the future include the second iteration of the behavioral health tracking form, as well as the final PIF and the final site visits and the final qualitative interviews. So those will be coming up in January and February. And with that update, I will now turn things over to Mr. Gordon.
All right, let us get situated. And Patrick, you should be unmuted now.
Okay, great. Can you guys hear me okay?
Yep, sounds
I
good.
will take that as a yes.
Yeah.
Yes, we hear you beautifully.
Okay. Okay, good. Okay, so thank you very much for the opportunity to kind of share our perspective here at Rocky with this project. We're very excited about it. We're very excited. We were excited to undertake this initiative because it occurred to us as a high leverage opportunity, something that could produce tremendous results with relatively little upfront investment. And this in and of itself, I think, has it appears to be turning out that way. But the thing I want to focus on really today is that integrated behavioral health, from our perspective, is just another aspect of our overall effort to kind of introduce population health management concepts within the delivery system, to create a population focus that rides alongside the long-standing encounter-based focus of our healthcare system, to put our physician partners in a position to more proactively address the needs of their patients, to plan, work a little bit more asynchronously than the encounter-based system allows them to do so, and to really roll this up into a model that allows both practices and patients to benefit from their efforts. So the key thing that I want everyone to keep in mind as you listen to the points I'm going to make is that behavioral health integration is really just another aspect of the overall comprehensive primary care model In and of itself, it's powerful, but it's most powerful when it's paired with several other elements of transformation, several other supports. And of course, one of the most important supports is the financial support. And so that's what I'll spend most of my time talking about here. I think most people would agree. There are thousands of people, hundreds of organizations that are all working to promote behavioral health integration within our systems of care. I think there's a recognition that regardless of what we do in healthcare, it's behavior that drives outcomes. And unless we can find smarter ways to support decision making on the part of patients and provide them the extra support that they require with behavioral decisions in the course of their lives, the better off we're going to be. But where the wheels start to fall off is, how is when people talk about how to do that and how best to pay for it. So I think everyone agrees that behavioral health integration is a good thing. They agree, as we did at the outset of this project, that there's a huge opportunity here and somehow we need to work on it. But what happens after that is pretty murky. From a financial standpoint, one of the biggest barriers I think that we run into is that we go right back to the well when we think about how to make behavioral health integration sustainable. We go right back to the source of many of the problems in the system, and that's the fee-for-service reimbursement model. Now, behavioral health is just another aspect of an effective team-based approach to care in advanced practice. In that regard, yes, there's a degree of professional training, licensure, credentialing. There's a definite set of skills and aptitudes that go into delivering the behavioral health interventions, particularly brief interventions in clinical settings. But that's just another resource on the team. And in that regard, it's no different than trying to integrate care management into a practice setting, or maybe integrate clinical pharmacy support or any of the other supports that are part of the comprehensive model. And yet, when we talk about behavioral health, because it's been carved out, because it's kind of been a separate entity for many years, and because our predominant system of reimbursement outside of grants is fee-for-service, we go right back to what codes we have to turn on. With SHAPE, Rocky was hoping to skip over all of that. We've kind of been there and done that. We actually see the same types of patterns unfolding, unfortunately, around care management. CMS has been promoting G codes and V codes and special codes to support care management, because that's a practical way of getting funding for these types of activities, but it still misses the point. And it also causes all sorts of impractical issues, questions about co-payments, questions about what types of activity can be coded. All of that, again, creates barriers for patients, and we think has the effect of pulling people away from the care team that we're trying to promote. So with SHAPE, we had an opportunity to just sort of skip over all of that and not talk about what codes to turn on or how to set a capitation rate or how long a grant might last, but really to look at a couple of fundamental things, which is first and foremost, what does it cost to deploy the resource? Not what we're going to pay, not what the PMPM value is or what codes will be active, but what is the underlying cost basis in the practice? And so Ben and team created a cost documentation process. All of the practices participating in the intervention went through and completed it, much in the way they would complete a budget for care management or other aspects of the model, and that became our basis. And starting with that basis allowed us to craft payments that really were focused on, first and foremost, sustaining the resource in practice. The practices that have been participating in SHAPE thus far know that they're going to receive payment. They know what their budget is. They know what the limitations are. We need to work on those. But the reality is we didn't try to reverse engineer a payment model to get to sustainability. We started with the concept that these new resources would be sustainable in practice, and then focused where we need to spend our time and effort on how do we actually promote integration, how do we begin to track meaningful metrics of performance and productivity, what limited set of measures should we be focused on, And how do we all roll this up into a single view of cost and outcomes? And that's where we spent most of our time. I think unless we can all get to that point, unless other payers, other researchers in this area can kind of move away from the frankly fragmenting approaches that have been necessary to sustain behavioral health and practice, we're not going to really understand or see the full impact of the model. So you can advance to the next slide, Emma. So again, the key concepts from our standpoint regarding behavioral health are the same that are present when we talk about comprehensive primary care or population health management in general. First and foremost, we, all the people participating in this project, the payers, the practices, the clinicians, the researchers, the HIT people, and last but not least, the patients, all have to be part of a process where we first come to understand what the population is, where they're receiving care, what their needs are, and developing a deep working sort of empanelment and population basis for all of our activities. We have to create a budget, just like we talked about. That starts with the inputs to the model, the practice-based costs for sustaining healthcare, but then we also need to have a global view. And where do these expenditures sit in the overall healthcare spending pattern? How do they relate to primary care and to the overall global spend for healthcare? And that's something that's often overlooked. When you look at it, you actually can see, and I'll show you in a minute here, how infinitesimal the investments in behavioral health are relative to the total spending, and even how small primary care is relative to the total. But that's that budget sort of view, that top-down perspective of where the money is going, is essential for this to be successful. Yes, we have to set specific targets. Rather than undertaking the usual approach of making the list of targets as long as possible, we really narrowed in the SHAPE project on those that we thought were most pertinent to this model. A target is not a target if it's on a list of 64 measures or even 32. In SHAPE, we have a handful of intermediate health outcome measures, largely process measures related to population health and chronic disease, and then 3 measures related to depression, substance abuse, and anxiety. And those are our newest measures. They're not widely used. They're not widely reported. But we realized that for this to really be successful, we had to account for what activity is actually occurring, account for processes that would be impacting, moving the needle on things like depression and anxiety, but not overwhelming the practice with a long laundry list of everything we can possibly measure. So the SHAPE is distinct in that it's very focused. And then from a data standpoint, it's allowed us to focus our activities as well. Chandra mentioned EHR extraction. That is not an easy undertaking. We are not in a world, and I think most of the people on this call know, we're not in a world where you push a button and get credible results out that can be easily reported. We're in a world where we need to, frankly, work very intensively with practices, identify what data are available, identify what changes in record keeping or data maintenance might be necessary to get better results, and then ongoingly provide that support. We've been in a position to do that because we know that that's important to do. But I think at the end of this process, we'll have a much richer data set to work with. And then last but not least, we'll be able to match the clinical data with the administrative data we see in our own global budget, and provide feedback to the researchers, provide feedback to the practices, and close the loop as much as possible. In that regard, as long as we can see needles moving and progress happening, we know we're investing in value. There's already plenty of evidence about the value of integrated behavioral health. And as I mentioned, we're seeing some of that unfold right now. And then at the end of the day, we, like any other accountable care initiative, we need to own the results. So this is something, whether we succeed or fail, or need to make course corrections along the way, we collectively, as participants, the health plan, the providers, everybody involved will own the outcome, and that's a fundamental principle. Okay, next slide, please. So I mentioned the global budget. These slides that follow are some of my favorite slides. I actually have a refresh of data that I received last week that paints the same picture, but it's even more compelling than what I'm about to share with you. And I hope in future discussions I'll be able to bring that forward. But here what you see is just sort of a basic spending pattern. This is our vanilla fee-for-service spending pattern within Rocky's networks. I think this includes Medicaid, Medicare, and commercial members all rolled up into one. And this is the value of spending on a fee-for-service basis across all participants. And what you see, of course, is that behavioral health isn't even represented as its own pie wedge. And primary care is second to last in terms of total spending within the system. Again, people know this. They know this pattern. This is the plight of primary care. But if you advance to the next slide, I'll show you what the opportunity is. The opportunity, of course, is to invest in comprehensive primary care and begin to change the distribution and also, frankly, begin to shrink the pie. It's not enough to just simply reshuffle spending. We have to shrink what we are using overall in the healthcare system, and that's what this is about. But here we're focused on a couple of the SHAPE practices representing a statistically significant population. And here you can see that the total spending that's gone into primary care is more than twice the level that typically goes in typical reimbursement systems. And you also see the piece that's actually related to the behavioral health budget that I talked about earlier, the cost-based practice budget. And it is less than 1% of total spending. In that regard, it is an infinitesimal segment of the model. It's small compared to primary care itself. And we need to keep that in mind when we're talking about behavioral health. It is not the most expensive investment. It is a tremendous opportunity. And again, when you look at it from the standpoint of a global budget, you can see that very clearly. You can see that with relatively small changes in how we allocate the resources that are available to us, we have the potential to get much better value. Next slide. All right, so this is my point about whether or not the second pie, where we're spending more on primary care, is bigger than the first pie when we're not. These are real numbers. This is real data. It's a little bit old. I need to refresh it here. Every time I do, though, it gets better. Here you see that the advanced practices for all their attributed patients have a total cost of about $479 per member per month. And then if we boil the SHAPE budgets down into a PMPM across that population, it's about $3.50. One side note is I then mentioned this. I invariably get questions about what the PMPM is supposed to be or how to set a PMPM. And I invariably try to avoid those questions because I think it's an after-the-fact issue. It doesn't matter what the PMPM is if it doesn't correspond to the total cost of care, if it doesn't correspond to the needs of the population, and if it doesn't pay for the underlying resource in the practice. So this PMPM is an outcome of the budgeting process that Chandra and Ben mentioned. It's not something that we plugged in advance. But you can see, again, it's relatively small in the grand scheme. And so with behavioral health and everything else piled in, you see that the total cost for the advanced practices is substantially lower than the total cost for all the other practices on a risk-adjusted basis. So we use a risk adjuster to account for differences in age and sex and diagnostic complexity and so on. When you get to an apples-to-apples comparison, the advanced practices are performing much better than the rest of the network. Okay, so next slide. And then we drill in. This is one particular exemplar. It's my favorite example because it shows the power of this model. And I always point to this exemplar practice because in addition to seeing these statistics, I know exactly what's going on at this practice. I know that among the other exemplars, they are farthest along in adopting the comprehensive primary care model. I know in comparison to the other practices, they've gone out of their way to take difficult, challenging, complex patients. I know among all the other practices qualitatively, they have the level of insight and the ability to execute on the model. And here we see the results over time. And this is a rolling 12-month metric that we put together and actually report out to all of our practices. The red line represents the network average. If I had extended this out more than 12 months, you'd see that it was bumping up along the usual healthcare trend of about 3 to 5%. And then you see the blue line, which is the raw cost of total cost of care for this patient, for this practice. And the total cost is higher, frankly, because they've taken on more complicated patients, taken on resource-intensive patients, patients, frankly, with lots of behavioral health and substance abuse issues. And over time, they have consistently, again, if you drew this chart out over time, you'd see they've consistently pushed that line down. The green line is the risk-adjusted line. And the number I reported on the previous slide was kind of an average. This one shows very significant delta in the total cost of care between the red line, the average, and where this practice is performing. And in fact, the non-adjusted raw cost is below the red line in addition to the normalized cost. It's a very powerful return on the investment. Now, do I attribute all of this to behavioral health? No, I do not. Is there any kind of easy pre-post analysis that we can do that allows us to see what intervention, what specific change caused this to happen, or when it started? No, we do not. What I do know is qualitatively that a lot of work has gone in to build this model over a long period of time. And I do know that as both the sophistication of the practice has advanced and the support that we've been able to provide has advanced, that the performance has improved. So if you scroll ahead to the next slide, I'll show one other piece. We see that in multiple dimensions. This is total cost. If you look at the next slide, this is inpatient utilization. Surprise, that's where the savings comes from. And again, over time, both the normalized and the raw cost have begun to trend downward to the point where they're exceeding the network average. And we can validate this. One quick point I would make, I'm mindful of time, but one quick point I would make is that these are views that Rocky has. But when I look at the views, for example, that CMS provides, where CMS has begun to make feedback available to practices participating in things like Comprehensive Primary Care Initiative, I see the very same results. And if we're able to move forward to a model, which I think we're on the cusp of here in Colorado, where all payers can aggregate data and report standard benchmarks like this, we'll get further corroboration that this model is producing value. We, as a payer, we have enough justification to move forward and continue investing in these programs, but the real key will be looking at other payer sources, other coverage types, and knowing that we're not just seeing things, we're seeing what we want to see, that this is actually playing out an independent analysis for other groups. Okay, so next slide. Actually, skip one more slide, please. I'm going to skip this one. Keep skipping. Sorry. Okay, so to kind of wrap this all up, we're very excited about what we're seeing. When I look at other analyses of the practices that are integrating behavioral health as well as working hard on all other aspects of the model, not just the one that I showed you, but across the board, they're continuing to get separation, pretty material separation from the cost and quality trends that we see for the network as a whole. Behavioral health is a critical part of that, and I think behavioral health will accelerate this faster. It's a small investment. It seems big if you talk about it as $3.50 PMPM, or you look only through the lens of what codes you're going to turn on. But if you actually start with how much this represents in the overall budget, you see it's next to nothing. And you can make a pretty logical decision to say, okay, we need to move some of our resources in the direction of those activities that are creating value. And that's the key takeaway here. Here's the hardest part, and this is where I always like to end with this. We're thrilled with how the exemplars are doing. We're thrilled with how our top tier practices are doing, and we continue to get great feedback that they're doing very well. But those are just the exemplars. Those are the top tier folks. Those are the folks who've been most persistent, frankly, undertaken the greatest risk in their own activities to move this model forward. The vast majority of other practices are not there. Yeah, I showed that network average. They're still operating in an encounter-driven fee-for-service model. They're the least reimbursed providers in the system. Next to, they get lower per unit reimbursement than emergency department. The emergency department is their biggest competitor in terms of total spending. And so how we get beyond this world of leaders and followers, or make transformation a broader based activity, I think is critical. And that's a policy question. It's going to take more than what individual organizations like Rocky and its partners can do. It's going to take alignment across payers. Government programs are going to have to change. We're going to have to wean ourselves much more rapidly off of fee for service and jump into a new paradigm. And frankly, we're going to have to look at things like what things actually cost at the practice level, because you like I said earlier, you can't do that in the abstract. You can't do that from the top down. Not so arguing that we're going to do cost-based reimbursement going forward, but I am saying that if you are looking at this as an investment and you legitimately expect it to produce returns, you have to approach it that way. And that starts with an understanding of the underlying, financial and operational barriers of the practice to moving forward. So I will stop there and turn it back to Chandra and Ben.
Thanks so much, Patrick, and just amazing to see some of the preliminary data coming out. And just so you all understand the power of those data, obviously, it's pretty impressive to see how some of the exemplars are doing in this space. But we also, and I wanted to add this to the dialogue, is that we've also, and Emma and Chandra have been doing this, been collecting the qualitative data and finding out just your stories, what's working and what's not, and how has this changed the way that you deliver care. And that those are going to be important elements when combined with the quantitative data like those that Patrick just showed you. So we've got just a few minutes left, and I wanted to stop and see if Emma, we were moving to questions, right?
Yep, and folks can ask questions either through the chat feature on the GoToWebinar control panel, or you can raise your little hand and I can unmute you and you can ask that way.
And if you have a big hand too, you can raise that as well. All
right. So we have one question, and Patrick, this question's for you. And from your slides, is the total normalized cost in the exemplar practice a PMPM or a PMPY cost?
It's both. I can't remember how I presented it. I think I presented it as a PMPM or PMPY, but it's just as easily converted to a PMPM. In the reports we give back to the practices, we give them both, and the trend lines look the same. So just a different term. And if I didn't answer your question, or if there was a question behind the question, please ask another.
Any other questions? If not, please type them in, or Emma can unmute you when you raise your hand. Okay, it looks like Dr. Reichs raised his hand, or he did and then he undid it.
Greg, do you want us to unmute you, Dr. Reichs? If you'd like to ask your question, you're unmuted. All right, we're going to mute you again. So our next question is, at this time, are you encouraging us to pursue billing for the additional services they are providing? I think that's what the question is.
Is that question for me, or is it for Ben?
I think this is a question for you.
Okay, well, that's a toughie. as I mentioned, I would prefer to be doing this type of global payment. We're working within a global budget across all sites and moving as quickly away from fee-for-service coding as we can. For example, and this isn't specific to behavioral health, care management. CMS recently came out with all sorts of guidance for practices saying, please bill for care management. And it even went so far as to say it's a huge financial opportunity, something like $43 PMPM. But what they neglected to mention is that copay goes along with all of those codes. If literally when you're said and done, you net out Part B cost sharing, it's more like $25 or 20. But the point is, why would the patients pay more? They come to the office, they expect to pay an office copay. Why would they expect that their copay would be higher just simply because of the billing mechanism that's being used to sustain the resource? It just doesn't work. And there are many other reasons why billing is problematic. The reality is, Rocky can do these global payments with a small number of people in a small place, frankly, where we have enough leverage as a payer for it to be relevant. There are many other excellent practices out there where Rocky is completely irrelevant as a payer. It doesn't matter what we do. And in those cases, if the only way to move forward is to do grants or to bill or to pester the state to turn on codes, fine, so be it. I think that will be hopefully useful in the long run if we're trying to create an experience base or at least, sustain what we have. But I don't want to be, what I worry about is that there is sometimes a confusion with that being the end of the process. And it isn't. It's at best a temporary step forward to a place where, again, hopefully we can get multi-payer and government program alignment and simply pay for these services that create value without trying to figure out how to wedge them into a CPT encounter-based billing model. We've got a ways to go on that. So I guess I would say if you can bill by all means, but don't confuse that with reform and don't confuse that with sustainability, because at the end of the day, I think that, as I mentioned, some of those coding requirements pull people away from the concept of team-based care and just won't work as well in the long run.
And I just want to add really quickly to what Patrick was saying. This has been one thing to remember, folks, is that we understand that, as Patrick just alluded to, we're not necessarily in the most perfect payment milieu yet. We're making progress, we're making steps. But one thing that we really want to have to help make that compelling case is not only some of those data that Patrick showed you around the decrease in spend or ED utilizations or whatever it might be, but it's also the breadth at which you all are offering services to a wide swath of your population. One of the challenges that comes from looking at the coding aspects of delivering behavioral health and primary care is that it does limit you to who you can see and what you can do, especially in that context. And so I just wanted to flag that, and I think Patrick said this really well, but you might find yourself in one of those cognitive dissonant type of states where you might see opportunities to bill a little bit more for the services, but it relegates you to doing a little bit less for more of the population. And this project from the beginning has been around the balance between the two, that idealistically we'd be able to provide that non-fee-for-service total holistic payment, and it continues to be that way. But really, you all, and Patrick kind of alluded to this, you all do what you have to do. But I wanted to just flag that from a conceptual standpoint. We really do want to try and show the depth at which you all have been doing and delivering these really robust population interventions.
Thanks. And Carol, I'm going to unmute you in case you had a follow-up question. I see your hand is raised.
Okay. Can you hear me now?
Yes.
Okay. Well, that was my question. And, I'm getting a ton of feedback here. So maybe, can you guys make an adjustment?
Let me try muting. I'm going to try muting everyone else.
Well, I'll just try to ignore myself, though. But anyway, Patrick and Dr. Miller, thank you very very much for your answers because you've given me exactly what I need. Um, what I'd like to say is that I wanted to clarify that you weren't encouraging us to go ahead and do the billing, because I agree with you very much. I think that a per member per month is the way that we need to go. We need to think of it as global, because as soon as we do start billing for it, we are going to see our patients back away from the comprehensive services that we are billing. We certainly don't want that to happen. We want to be able to look at each individual patient, regardless of what insurance it is, and we don't want to fall into the trap of selecting services based on what type of coverage or the patient's ability to pay. So I appreciate the fact that you've clarified it, and that we don't have to consider the trial period of picking and choosing which E&M codes we could try to do for sustainability. So thank you for your answers.
That's great, Carol. Yeah, we just have to find a way to kind of push that concept forward, because there's so much focus on fee for service billing, that I think we are losing the forest for the trees.
All right, so our next comment is the cost-based payment model is both a blessing and a challenge. It is easy to allocate cost of your integrated behavioral health specialists. However, allocating costs of behavioral health integration over all the other activities in the practice is much more challenging. It is not black and white. If this is a model we are trying to spread, practices need additional education and tools to develop these budgets.
Yeah, whoever said that, I agree 1,000-fold. It's relatively easy to figure out what an FTE costs. It's hard to understand how that cost relates to your overall transformation program and your overall operation. So I think, in fairness, we have a ways to go. And then I want to be very candid about this. It's one thing to say, okay, we're going to pay for an FTE or an FTE and a half or whatever. But how do we know that that's sufficient? That's not really integration. There's not really a process by which we align the count of FTE, the mix of skills, all of that with the size of the population, the needs of the population. So in addition to putting additional practices in a position where they can do this, in the practices that are working at the head of the pack, we've got to actually figure out how to scale this and better align what we do with the needs of the population as a whole. So we have a very long ways to go. But the question you asked is getting right at the heart of the problem, which is that, many times the practices or the people who are trying to support these efforts know what they're doing, and we have to figure out how to learn together.
So we have time for probably one more question if anyone has anything else or another comment to add.
Well, thank you all very much for your time today, and thanks for the opportunity to share a little bit about where SHAPE has been and where it's going. And those of you that plan to attend the Collaborative Family Healthcare Association conference this week, I know that we're going to try and get together with some of you, and we look forward to seeing as many of you there as possible. But definitely, I encourage you to connect to other folks that are at this meeting. It's likely that you'll find that there are people that are going to ask questions around how do you pay for your care. And I hope that today's webinar and a little bit of an update on SHAPE will give you a better answer to that question than just we're scraping together the coins that we find in between the cushions of the couch. And so as this project wraps up, we do look forward to, as Patrick said, continuing to talk with you, but also how we can use you as some of the leaders in our community to scale, put you on stages and on webinars and put you in front of the right people to tell your story on how projects and efforts and payment methodologies like these really are highlighted and get a lot of attention. So thank you all again, and if you have any additional questions or comments, please email us, but if not, we will see you in DC.